Senate Regulated Industries Committee meeting to order. We have two bills on the agenda today. One is my bill dealing with certificate of need for cancer treatment, and the other is Representative Earhart had a bill, I believe we passed it last year,
Yes.
House Bill 185 on Dietitians Practice Act.
That's correct.
I'm going to flip the order because you have promised me you can do your bill in 3 minutes.
It is fast.
But I want you to take enough time to remind us, we have a couple of new committee members, what it's about, why you're bringing it, and what it does.
Happy to do so.
So I'm going to turn the floor over to you on House Bill 185.
Thank you, Mr. Chairman, and thank you to the members of the committee for hearing the bill today. If it looks familiar to some of you, it's because you've passed this bill unanimously twice before. In Georgia, the Dietetics Practice Act has not been updated in 32 years. It is outdated and in dire need of an overhaul. That's exactly what HB 185 does. It overhauls, cleans up, modernizes the language of the Dietetics Practice Act. It does some key things. It provides additional pathways to licensure for more qualified nutrition professionals, ensuring that patients have access to competent, evidence-based nutrition care. Simultaneously, it narrows the licensure requirements, focusing in on the practice of medical nutrition therapy, MNT. That is the practice of nutrition or the diagnosis and prescribing of certain diets to actually treat medical conditions. This ensures that only those with the highest level of training can manage complex nutrition-related conditions. That's one of the most important things that the bill does. It expands licensure exemptions so that non-medical advice can be given. So what we're talking about there, the folks that would not need to be licenses, those are your personal trainers, the coaches in the gyms. This ensures that your child's t-ball coach doesn't have to have a nutritionist license to give nutrition advice or tell the kids how to eat healthy. The bill also facilitates multi-state practice, allowing Georgia to enter into a multi-state compact, and that is going to be probably the bulk of what you see in the bill. You know the advantages of this. It improves the license's portability. It expands employment opportunities, certainly helps our military spouses that relocate to Georgia, and reduces the burden of requiring folks to have multiple state licenses. The bill is It was a good bill 2 years ago. What was 1 year ago and 2 years ago, and we think that it's still a strong bill. I did also want to introduce Robin Stegall. She is with the Georgia Academy of Nutrition and Dietetics. She does a better job than I do speaking to the nuances of medical nutrition therapy. That is the bill in a nutshell, and I'm happy to answer any questions if there are any.
Okay. Let me ask you just a couple of questions first, Representative. I remember the bill from last year. Everybody may not. Please explain the difference between, a dietitian that needs to be licensed and somebody working in the school lunchroom.
Exactly. Education has a lot to do with it, the educational requirements. Certainly, the nature of a licensed dietitian, and I may have Robin, she says it so much more eloquently than I can, but the licensure with a dietitian, that is ensuring that dietitian has been medically trained to use diet to help treat conditions. So this is just not for the purpose of overall health. This is to treat conditions through medical nutrition therapy. That is the big difference between that and someone who might be teaching kids about, the food pyramid, the updated, I might add, new
Are
food
they
pyramid.
currently licensed?
Currently, we have one broad, generic nutritionist license, and the truth be told, it's confusing. Robin, would you like to speak to
No,
that?
I'm going to let me finish with you
Yes.
first. She's the only person lined up to speak, so we're
Okay,
going to get
so
her
we have
next.
time.
I'm not going to make you stand up. I have sympathy for people with leg and foot injuries. Saw you hobbling.
Is there nutrition therapy for that? I don't think so.
I
Okay.
need it. So, there is a license. Now it's under nutritionist. Just tell us why you want to break it out in a separate license. Why not just continue being licensed as a nutritionist?
Right. This is actually, the projection is there might actually be fewer licenses, even though we're going from 1 to 2. Right now, the license is overly broad. It doesn't reflect the changes that have been made in medical nutrition or nutrition therapy in general over the past 30 years. So the concept here is that there is some confusion on the part of consumers as to whether or not a licensed nutritionist has the training and the knowledge to treat a medical condition, or just really honestly someone who really should just be giving advice on healthy
got
eating
it.
in general.
And then walk me through why your people would want to be a member of a compact where the rules and regs are controlled by multiple states rather than just the state
Understood.
of Georgia.
Georgia is setting the rules and the scope of practice in this state. So if a nutritionist or a licensed dietitian moves into the state, they are going to have to practice under the scope that is outlined in Georgia law. It's simply saying that we will allow, as you know, or if you've probably read this, is that when nutritionists or licensed nutritionists, dietitians move into the state, we will accept their licensure, assuming that the state that they came from has an equal or greater higher standard,
Or a member of the compact.
or member of the compact, right?
Is that why military likes this so much? Because it helps their people when they get
100%.
transferred?
And I've always been a big fan of compacts within reason. Certainly, it helps our military personnel. I grew up on Army bases. That was my life from kindergarten until high school. I was on a different military base every 2 years. So I understand, in our military community, what it was like when those families would get transferred. The husband or the wife would transfer in, and then the spouse would come along. It could be nurses, could be dietitians, could be counselors, and it was always a struggle. And there was often, and we've heard this before for folks that talk about compacts, there's often this period, 1, 3, 6 months before that spouse can get licensed in the state of Georgia due to a number of issues and challenges with getting licenses.
Okay.
So we
Any
think
other
this is a
members
positive
have
step.
questions for Representative Earhart? Mr. Pro Tem, you're recognized for a question.
Representative Hay.
Hi there.
So we're adding a license, which is,
Under the same, yeah, right, same licensure, but it's licensed nutritionist, licensed dietitian.
and you're going to add some people to the licensure board.
Yes,
We're going to add one person, one additional person.
one additional member to the board.
And then it looks like to me maybe you're going to require one specific accrediting agency to be the official accrediting ASCEND, Accreditation Council for Education in Nutrition and Dietetics. And so I've had concern putting specific accrediting bodies by name in code and statute. Have you shared that concern? And we see this quite frequently,
Right.
where you're going to, put in code this name of this
Particular
entity
accrediting
that's got to
body.
be, bless everybody before they can go to work.
Right.
And I have a fundamental problem with that. I don't think it's good. Public
Right.
policy, their name could change,
Yeah.
whatever. It does say, or its successor organization, but there could be
Right.
another entity that comes
Right.
forward that's equally qualified to give accreditation to people. So where's that coming from?
Right, and I do share your concern on that, certainly as relates to K-12 accreditation, higher education. My understanding is that there are some limitations on the accrediting bodies for nutritionists, and I don't know, and Robin, perhaps you can speak to that better than I can. I don't think there are as many options for accreditation, but
Yeah, so,
please.
is this on? My name is Robin Stegall. I'm a registered dietitian. I'm also the Government Affairs Committee Chair and Public Policy Coordinator for the Georgia Academy of Nutrition and Dietetics. So if I could speak to your question, Senator Walker, the ASCEND is the accrediting body for dietetics education, and it's the only body that accredits programs for that dietetic internship, which is a large part of our supervised practice, and how dietitians achieve the 1,000 clinical hours or 1,000 hours of qualified supervised practice to work in high acuity in and outpatient settings. And ASCEND is the body that we rely on for those programs to be verified and the standards to be set. But the language within the bill does provide for, should a different body or a different group become the group that is in charge of that, for that language to also be acceptable.
Can you point to that in the bill where it provides for that?
Like 788.
728?
788.
788.
I didn't get that far into it.
Next page.
If it's part of 788, then that might be part of the licensure compact language.
Right here.
Yeah,
Okay. Right.
let me, hold on. Just a second.
So aren't we gonna do away with the U.S. Department of Education?
No, so this is a very long bill, and the part, Senator Walker, that you're referring to, that line 788, is actually part of the boilerplate language for the licensure compact. That language is not the language that's part of the specific licensure statute for the folks here in Georgia. So that language, referring to the standards of practice or the scope of practice for licensed dietitians, the educational requirements, all of that is covered in the first half of the bill. And the second part, and that ends on page, that ends on line 624, on page 25. The rest of that from line 626 onward is the standard licensure compact language
Right.
that covers our participation in the interstate licensure compact.
Right.
Mr. Chairman, one more question, if you don't mind.
One last question.
How many states are in the licensure compact currently?
Yep, so we've achieved 11. We've got 15 states that are putting licensure compact legislation forward this year.
Thank you.
All right, other members have questions? Stigall, did you have anything to add? You were lined up as a witness.
I would just say that this substitute represents just again further refining that that took place during the when the session adjourned last year. The main language changes were to provide some clarification around complex versus non-complex care, in lieu of the language that we had used prior, which was chronic and acute conditions, to define medical conditions, just providing additional clarification around complexity of care, and the relative level of the location of where that care is provided, depending on the stability of the patient and the health of the patient and the complexity of their diagnoses. So we just added that language in lieu of the chronic and acute language
Okay,
to tighten it
thank
up.
you. Any other questions? All right, we're in a posture where I'm willing to receive a motion that we're working off of LC 52098-7S. It is a new committee substitute. Got a motion by Chairman Brass to do pass by committee substitute, second by Senator Summers. Any discussion or any proposed further amendments? Senator Rhett, you are recognized.
I was just gonna say, I won't hold it against her because she grew up on Army bases. I tried to eat at some of those chow halls, and you need a dietitian.
All right. We're going to take that as an indication you favor the bill. Any further
for that.
discussion? All right, all in favor, raise your hand. Leave them up long enough for Paige to get your names down. All right, all opposed, same sign. Got one opposed. New committee member causing trouble already. All right, the bill passes. Now we're going to move on to the next bill.
Thank you.
We're going to do this as a hearing only. I have 1, 2, 3, 4, 5, 6, 7. I got 8 people lined up to speak for this bill, and none of them even checked the box for or against. So we will be interested to learn what the sentiment is. I have had, this bill has been pending since the very end of last session, and made one small change that got some reaction, that it didn't have to be exclusively dedicated to cancer, but could also be primarily dealing with cancer treatment. And wow, you would have thought I had come up with some new legal term to say primarily, and I kept being asked, why don't we define it? And I even went to Westford Dictionary to try to figure out exactly what it is, and it's exactly what it says. It's either predominantly, mainly, for the most part, chiefly, principally, substantially, largely, mostly. That's what Webster says. I don't believe there's any confusion what primarily is. That's predominantly what you're doing. And what the amendment changed, adding exclusively or predominantly, or, excuse me, primarily at several places, was just to let it know that you could have some services other than cancer treatment, so long as that's your primary purpose is the cancer treatment. If somebody out there has a better way to word that or to define it, to give you assurance that this isn't allowing somebody to come up and do 10% cancer treatment and avoid the CON process, bring it on, let me know before we bring this back up for a vote at a later meeting. I have also had it pointed out to me that if you go through the CON process, you are required to do indigent care at the 3% level. Y'all are all familiar with that language, and that it would be a weird anomaly to allow you to be exempted from CON and also not be forced to provide indigent services. If it were up to me that I could wave the wand, not many people in this room would like me, because it'd be about 10% and be a whole lot less squishy definition of indigent than we have now. I think all of these hospitals that say that they're nonprofits or not-for-profits in particular ought to be doing an awful lot more indigent care than they're doing. So I have an amendment. It's the first thing in your folders that makes it clear. And I took let everybody relax, it's the exact language from 1339 that passed last year that applies to all other areas that are exempted from CON. It's the 3% level is the easiest way to say that. And so, but it is verbatim from the language from 1339 that passed last year, that you should provide this is for members of the committee after line 37 in the bill in front of you, to say provide uncompensated indigent and charity care in an amount equal to or greater than 3% of its adjusted gross revenue and on and after January 1, 27 in an amount equal to or greater than the minimum amount established by the department by rule, which shall be at least 3% and which shall be reviewed by the department every 12 months. We will not take that amendment up today. We're not going to vote on the bill today, but we're going to get the sentiment of our public on this. I will tell you that the idea is pretty clean. Cancer is the second leading cause of death in Georgia, and I think it's important that cancer care and treatment be available to as many Georgians as possible, and the CON process is an impediment to that. I'm going to be interested to hear if there are healthcare professionals that think we ought to restrict access to cancer care to our citizens in any part of the state. But let's hear what people have to say. That is a relatively concise explanation. I can tell you I've explained, many lobbyists have come talk to me about this bill to ask what I'm trying to accomplish, what I'm trying to do, and it is that clean. It is a rifle shot as to the illness that I want to make it easier to get treatment for. It is narrow. It is cancer, any type of cancer. But the breadth of the CON limitations is broad. It's a shotgun blast. Anything you're doing, equipment, facilities, new businesses or whatever, to address exclusively or primarily cancer treatment, we want to get rid of all those barriers. So it's precise and limited as to the ailment, condition, illness, whatever we're going to call cancer, which is literally our number 2 killer. That's only treatment for that or primarily that condition, but in many different aspects. So I am going to take people a little bit out of order. I know where a lot of folks stand, and then you'll be surprised how many groups are sort of agnostic on this or neutral on it. But I want to hear what you say, good or bad. I'm an elected official. We got pretty thick skin. I can take the pros or the cons. Just let's educate us so we don't do anything dumb here. I'm going to start with my friend Dr. Nick, and I can't pronounce your last name any better than anybody else, and that's why I call you Dr. Nick. But if you will take the podium and you can tell them your name, and you might better tell Paige how you spell it, who you're with, and whether you're in favor or against this bill. I hope you're for it, because y'all are my motivation.
Oh, it's a no-brainer, so I am for it, yes. Thank you, Senators. Thank you for inviting us. I'm a medical oncologist. My name is Petros Nikolinakos. They call me Dr. Nick for obvious reasons.
Say that again 3 times really
Yes,
quick.
sir.
Nick,
That's Petros Nikolinakos.
All right.
Nikolinakos. It sounds prettier when I say it.
Glad to have you here all the way from Greece.
Yes, sir. born and raised in Greece. Been here for 26 years. I'm mostly here as a patient advocate, but right now I work in Athens. We have a big practice there, a big cancer center. I don't know if people know about it, that we built a couple of years ago. We have 25 doctors. We have 500 employees. I'm the kind of cancer doctor that gives chemotherapy, but we also have surgeons with us. Dr. Griffin is here, Jim Griffin from Athens as well. He's a surgical oncologist, and we have colorectal surgeons that operate the hospital, radiation doctors that deliver radiation care, radiologists, nuclear medicine doctors, all kinds of people. We see about 13,000 new patients a year in our practice, 13,000. And that number has doubled, by the way, in the last 2 years. We've been in Athens since 1983. My practice. It's privately owned. The doctors are independent. They like it that way. They don't enjoy being employed. They like making decisions, being nimble, and being at the forefront of new treatments and therapies.
What's the name of the center? I'm not sure you
It's
explained.
University Cancer and Blood Center.
All right.
And so we've been in this business for a long time. It's exploded in terms of new treatments that are available for patients, new procedures, new diagnostics. It is an incredibly complex, orchestrated effort to bring new cancer treatments. We have a big research facility in our practice as well. And we try to deliver care locally, so they don't have to travel outside the city. People hate driving anywhere. In order to do all this stuff that we do and take care of patients, and I'm a practicing doctor as well as the president of the University Cancer and Blood Center, but I'm a practicing doctor first and foremost. I just did my clinic this morning and finished and drove up with Dr. Griffin here. And I can just give you an example from this morning about how CON is viewed from a patient's perspective. It's not viewed as a regulatory policy. It's viewed as a waiting list. And we have to constantly battle wait times. And this may sound like a minor issue, but when you're diagnosed with a potential cancer and you're waiting for treatment, for somebody to tell you you've got an incurable cancer, or what it is, the word itself is frightening to patients. So being able to tell them in a timely fashion what they have and what we're going to do about it is very important for these people. When we have to wait 3 to 4 weeks to get a biopsy or do a scan or have surgery and have to fight to get and do favors and beg and plead staff in hospitals or other facilities that we are not allowed to have access to, that impacts the patient. So I'm just here as an advocate for the patients. The amount of cancers that we deal with are increasing. The treatments are more complex. We need quicker access to these new treatments, to the established treatments. We need access to the diagnostics. We need access to the surgeries. We need to be able to take care of these patients in a fair way, in a quick way, to eliminate anxiety, to delay diagnosis, to prevent death, to prolong life, to minimize side effects, and to make people's lives better. The CON laws are antiquated. They don't apply. A lot of states already have eliminated them completely. And you'll hear from other practices here, people will sometimes have to go to neighboring states to do what they do, to provide care in a timely fashion. I can talk about the cost of care and how much cheaper it is in the outpatient. I can talk about how it frees up space in hospitals if we do it in the outpatient so they can do more things that are applicable to a hospital in the inpatient facility. Hospitals have a tremendous role in the community. They are undoubtedly important in the delivery of care, especially for emergency room trauma, neonatal care. But there are a lot of things that don't need to be done in a CON-protected environment within a hospital system that can be done in the outpatient to free space in the hospitals to do what they do best and for us to do what we do best in the outpatient setting. So I'm asking that we free up these rules, just like many other states across the nation, to be able to deliver the care that we need for these patients, to eliminate suffering and wait times. And so that's my argument. It's a very simple argument. It's not complicated.
Does UCBC operate under a certificate of need currently?
No.
Tell me about the PET scan machine you got last year.
So last year, we went through this process. We were we were begging the hospital to get another PET scanner. A PET scanner is a device that is like a CAT scanner, but you get injected with a radioactive drug, and then the drug goes wherever the cancer is and gives up a light signal. So I can see where the cancer is in the body and tell you if it's spread, if it's a stage 4 and incurable, or anything else. The wait times were 3 to 4 weeks for years. Plus, we needed to do tests that were not available and were not brought in. Since we got the PET scanner,
Were you able to get a certificate of need for that device?
well, we don't need a certificate of need anymore. That was eliminated for that study. So we were able to we got it the next day. And since we did, we were able to do scans in 2 days.
You're saying the next day after we passed the
We
bill
submitted an
last year.
application, we put the order in, and we got it right away.
How long had you been attempting to acquire or obtain that type of scanner?
5 years.
Okay. And why were you unable to get it before we passed the bill last
We
year?
were fighting in court with the hospital systems to try to, they wouldn't let us. They wouldn't get another PET scanner either. So we were just stuck in court trying to fight it the way that it was supposed to be fought
You
at the
couldn't
time.
purchase one without first getting a certificate of need for it?
Yes, sir.
All right. And once we passed the law and eliminated that requirement for PET scans, you got it the next day?
Yes.
All right. What is it you would like to do in your practice today that requires a certificate of need? And why do you need this bill? Or what exact type of procedures or treatments or facilities or outpatient centers do you want to do that you can't do under the current law?
There's a number of things. One simple thing that you may not think is important, but it is to put a port in a patient to deliver chemotherapy, is to do an operation in an outpatient facility where they don't have to wait for somebody else to do some other operation in the hospital and free up space. Operations and surgeries are very important in the treatment of cancer. It's not just medicines and drugs. We'd like to free that up so we can have operations in the outpatient setting that can be done appropriately in the outpatient setting, that are now being restricted in hospital settings and added to wait lists and OR availability. The OR availability is a huge problem, not just in Athens, probably everywhere. People fight to get in line to be able to operate in a hospital to take care of a patient. I'd like to see that go away. I'd like to free that up so anybody who needs a surgery for a life-threatening condition like a cancer can get it without restrictions, because it is important to treat these patients timely. If you don't do it quickly enough, these cancers will spread and they will go somewhere else. And then surgery is not even an option anymore. So I would like to have certain kinds of operations, certain kinds of procedures, certain kinds of endoscopies for diagnosis. I would like to be able to have my patients get something called an ERCP or an EUS, which is endoscopically through the mouth, down the stomach, into the pancreas, where we can biopsy pancreatic lesions, where we can biopsy stomach lesions, where we can do all these things that we need to do that require more advanced anesthesia, for example, that has to be done in a hospital right now. And that's what the CON restricts. It can be done in the outpatient setting. A lot of times it gets done in the outpatient setting in the hospitals even. But we're not allowed to do it. We have to wait in line to get all these things done, and they're already swamped. I mean, right now the hospitals are expanding ORs. It takes them years to expand them, and a tremendous amount of money to really expand an OR space in a hospital. We've been waiting 5 years for the hospitals to expand their ORs, 5 years. And we're still waiting. And we got to wait in line. Our patients are waiting to get surgeries that they need, or they have to travel to Atlanta. They have to go to a different center, an hour and a half, 2 hour drive, sick, with their family members to go some other place to do the procedures.
I have a couple of committee members with questions for you. Senator
Yes, sir.
Summers, do you have a question, or did I already ask it?
You asked one, I have one more.
You're recognized.
Thank you kindly, Mr. Chairman. If you do these procedures in your clinic, I'm assuming that's what you'd call it, your facility.
Yes, sir.
Would you not be basically taking away any revenue to the hospital?
The hospital is inundated with these things already. They can't accommodate us. That's a great question. When we were fighting for the PET scan in court for 4 years, being opposed by the hospital system, the argument was that it would take away money from the hospital. Well, the hospital wouldn't get another PET scanner, number one. I was trying to reassure him that the volumes justify not one more PET scanner, but probably 2 or 3, and they wouldn't believe me. So we got the PET scanner a year ago. We need a second and a third. we are maxed out now, they are maxed out, and we still need more scanners. That argument does not hold water. I want to pull out, that's one argument against that. The other one is, I want to free up things that we can do in the outpatient setting that are a lot cheaper, cost less, bring less money to the hospital, and free the hospital up to do the bigger complex things that need a hospital, that a hospital was made for. And they will make much more money doing that if we free up space and OR time. And they don't have to build more ORs, which is also expensive. If we decongest the stuff that can be done in the outpatient setting by eligible physicians and physician groups that that are still under the proper accreditation, certification, all that stuff, and free up the hospitals to do what they're meant to be doing, we will improve their financials. We will decrease the cost, not just for the hospitals, but for the patients and their copays and the insurance companies, because everything we do outpatient is much cheaper for the patient and for the insurance companies, and the hospitals can take on the big things, and they will have plenty of opportunity to make more money than that. It will not take away from them. That's the same argument I heard with the PET scans, and it's not true. It is just not true. It's sometimes about control. It's sometimes about other things that have nothing to do with the actual patient care. I'm just advocating for patients.
One follow-up.
One follow-up.
Yes, sir.
Okay, I got that. Just to make
Sorry,
sure.
I'm a little impassioned. I don't mean to be.
No, not, yeah, very, very. If you have these centers and you can open up a center and do your own thing, could you not go do your own thing in Albany or Columbus or Augusta or Valdosta? I mean, could you not take what you have and go down there and do that same thing and take away from that hospital that might not be overcrowded like you are in Athens? I mean, is that a fair question there?
I'm not interested in going to those places, first of all.
Well, excuse me, if we eliminate this con, then it allows other people to do what you're doing, this CON.
Other people have the same issue. You'll hear from the Augusta physician, they have the same issues. It's everywhere like that. Everywhere we serve the rural communities of Georgia. I mean, we serve 60 counties in the northeast of Georgia. It's not just Athens, there's 130,000 people. We serve over 500,000. We drive an hour away around Athens to different satellite clinics. We have 9 satellites around Athens in rural places of Georgia where we try to bring them for care. We're drawing all these patients to the hospital. We bring volume to the hospitals. The argument that we would go somewhere outside far away or somebody else can do the same thing, I hope they do. That's the whole point, is to decongest the hospitals from unnecessary surgeries that could be done in the outpatient that are lower cost and give them what they actually are supposed to be doing, which is higher cost, and they make more money, and they're free the ORs, and they're decreasing their expenses. That's true in every part of Georgia. We need to free up unnecessary things to be done in the hospitals. Like, you don't need to do certain things in the hospital, like a small hernia or a small this or small that. You can do that outpatient. Even in cancer surgery, there are things that we can do that are smaller scale that we should be doing without wait times in an outpatient facility. I don't want to compete against the hospitals. This is not about that. This is about making care more efficient and delivering better care in a timely manner to the patient. It will not take away anything from the hospitals. And if there's a practice, like you were here from another practice now, they have the same issues. It's just replicated everywhere, from city to city to city.
Thank you, Mr. Chairman.
Thank you. That's all the questions we have for you. Let me call on Dr. David Squires from Augusta Oncology.
Greetings. Thank you for having me here today. I'm David Squires. I am a practicing medical oncologist. I've been in Augusta since 2003. And I had clinic this morning, too, and made it over here so I could testify. I appreciate your consideration of this. I am the CEO of Augusta Oncology, also known as AO Multi-Specialty Clinic. We have many different specialists in our clinic, including medical, radiation oncology, surgery, urology, rheumatology, and we serve a population of about 800,000 in the CSRA, which we sit right on the border of South Carolina and Georgia in Augusta. So we have 5 clinics there. One of them is in North Augusta, and the other ones are in Augusta. And we see about 40,000 patients, active patients, and they get treatment of one sort or another. We see not only cancer patients, but patients who have iron deficiency, people who need drugs for osteoporosis, any kind of infusion for rheumatology, neurology, et cetera. So we serve a large portion of our community, and it's only us and the Medical College of Georgia that see these oncology patients. Our practice sees probably about 75% of the oncology patients in our community, and we are completely maxed out seeing everybody we possibly can. But so is MCG, and we have a wonderful relationship with those physicians at MCG, which is owned by Wellstar now, and have collaborated with them for many years. We pay their gynecologic oncologists to come into our offices and see patients so that they don't have to travel too far to go see another gyn-onc. And that's been going on for 20 years. We participate in their clinical trials with them. And so we send patients to them for stem cell transplants, for other very highly specialized therapies in oncology that require specialized nursing care. And we appreciate our collaboration with them. We meet with them regularly, as well as the CEOs from all the hospitals in our region. And I have to just comment about this general concept of CONs. These were, the CONs, Certificate of Needs, were developed in the 1970s under the consideration that if we had these Certificate of Needs, it would reduce the cost of health care. And so across the country, the federal government pushed states to enact these laws, and in 1979, Georgia enacted the CON law. But by 1987, it was clear that instead of reducing the cost of care, it was increasing the cost of care. It had exactly the opposite effect.
They were
And
trying to avoid duplication of services
Correct.
unnecessarily.
Correct. And in 1987, the federal government stopped the requirement, the mandate, but then each state gradually has had to make their own decisions. Some have phased it out gradually, and some have eliminated them, some have kept them. But the whole healthcare economy has shifted drastically in the last 45 to 50 years. The whole world has changed. And now in the last 5 years, 3 years with AI, I mean, you go back 10 years and it's like the dark ages. We have had so many technological advances now. Our cancer patients are living 2 to 3 times longer than they used to because of all these crazy drugs and radiation therapies that have come out. It is insane. I have so many patients who are stage 4 terminal cancers, and they're alive 10 years later with no evidence of disease now. We have technology that has very rapidly outpaced these laws that have been in place for 50 years. And so we have to kind of get out of this scarcity thinking and move into this more abundance type thinking. All healthcare facilities are overwhelmed. There is no competition in our area for seeing cancer patients because there are just too many for the providers to see. And so we have to work with the other facilities and say, okay, can you take these patients? We'll take these. You're really good at this, we'll send you those patients, and we're really good at this, and we'll see these patients. It is just like a triage every day trying to take care of these patients and work with the other facilities. And so we feel no competition with the hospitals. We appreciate them and love working with them. And so I think in our current healthcare economy, we have room for multiple models of healthcare, offering innovative and cost-effective outpatient options for patients, as well as these robust hospital service lines. But like Dr. Nick was explaining, it takes a long time to get patients in for services who have cancer. I myself am a cancer survivor. I went through chemotherapy for 3 years after I discovered I had cancer, looking at my blood under the microscope, and I was going through medical school during those 3 years. So it cost me $100,000 the first 6 months of my treatment with insurance. Those are my co-pays and deductibles back in the 90s. And so I have a very passionate view about how to help patients with these healthcare costs. The costs are definitely rising.
Will this bill affect cost, lower cost?
Oh, yeah.
If you eliminate CON requirements?
It will. If you do
Explain
that
that
for
to us.
outpatient services, particularly for oncology, yes, just as an example, we do CAT scans in our offices. And a patient, for example, will come in and say, oh, I got a $250 copay. Well, let me do it at the hospital. Well, they go over to the hospital and it's a $500 copay. They get radiation in our facility. They got to pay $60 a day. They go to the hospital, it's $110 a day to get radiation.
You're able to do radiation?
Yeah,
Did you have to have a CON to do that?
no.
Okay.
In Georgia, we did. And so back in 2022, we decided to purchase a 15-acre piece of property right on the corner of I-20 and Wheeler Road, a half a mile from our current main office on Wheeler Road. because we're maxed out seeing patients in this 25,000 square foot facility. And we needed a bigger facility, and we thought cancer care now is kind of consolidating where radiation and medical oncology and the surgical oncology groups are in a building. And it's so much better for patients to receive care in that way. And we can deliver care at a much better cost. So we applied for a CON to have radiation at that 15-acre plot that we had it all designed and everything. And we went to the state of Georgia and said, hey, can we do this? And they said, yeah, well, you will qualify under the exemption that you will save the state a lot of money for Medicaid and state health insurance because you will charge about half of what the hospitals are charging for the exact same services, outpatient services. And the patients will pay less. So yes, you should be able to get the CON. So we did all the work, did all the attorney fees, submitted it, and we had opposition from the two hospitals that had the radiation facilities in Augusta, Doctors Hospital and MCG at the time. And so the state came back and said, well, sorry, even though you applied under that exemption, we can't do that because of pressure from these hospitals not wanting this to be offered in that area. Well, they told us that in June of 2023. Are you aware of what happened in June of 2023 in South Carolina?
No.
They eliminated the outpatient oncology CON laws in June of 2023. So since we sit right on the river, we said, well, we got rejected in Georgia, we'll just put it in South Carolina. So immediately we acquired a property in South Carolina, about a tenth of a mile from the Georgia border. And it's a 60,000 square foot facility. We have 15,000 square feet of radiation. And we opened almost a year ago, February 17th, 2025. And in our ribbon cutting ceremony in 2024 and in our grand opening in 2025, the lieutenant governor, state representatives, and senators came from South Carolina because we were the first group to actually take advantage of the fact that they eliminated the CON laws for outpatient oncology services. And so we are treating hundreds of patients now in the radiation facility, and we moved our medical oncologist from one of our facilities in Augusta down by Wellstar and Piedmont Hospital just over the river, because now they're less than half a mile from the hospitals, but they're just directly right on the other side of the river in this amazing facility, 300,000 square feet medical oncology. So now the patients have to drive just a little bit further, but it does save them money, and we're able to provide them these services rapidly, conveniently. They can walk upstairs, walk downstairs between the two different medical oncology and radiation oncology groups.
Are there other services your business would like to provide that require CON that you have not been able to get?
Well, not at the moment. We still have that 15-acre property a half a mile from our other office, one of our offices in Augusta, that we would like to build another similar radiation oncology and medical oncology facility in a few years, but we don't want to go mess with that right now because we'll just get rejected again. And so
your patients that live in Georgia are driving across the river to your
Yes.
South Carolina facility, and they're getting cheaper medical care because there are no CON restrictions?
yeah, it only takes them 15 minutes extra to drive over there, but it saves them $50 a day for radiation oncology.
How much?
$50 a day.
Okay. And why is it cheaper?
Because we don't have facility fees, and we also don't charge as much. And so the patients pay a percentage of the radiation fee. So they pay 10% of the radiation fee every day. The payer pays 90%, and their copay is 10%. So
Is that covered by Medicaid?
yeah, Medicaid, same thing. I mean, yeah, we're sending our Medicaid, Georgia Medicaid over there, state health, everybody's going over there because we control about 75% of the radiation that occurs in our region. We manage, we control. So we just essentially are sending them all over there. We foresee a need for this in Georgia too in the next 3 years, but we don't want to go through the political, use our resources to go through the political process of getting the CON there.
Somebody may file an objection to it, block it, and then you're tied up in court for years.
Right. Interestingly, one of the state representatives who opposed us initially on getting the CON now called me and said, hey, what would it take for you to put it back here? I think we could help you with that. I'm like, we don't want to have an argument. We have a great relationship with the hospitals here. If it goes away, then we'll consider putting it over here. We have the property. We're ready, we'll do it when that time comes.
It doesn't sound that great if both of them blocked your application for radiology services.
Well,
They
it's
charge
interesting.
$50 more.
The relationships between providers is very interesting because at the top, the administrators, those who haven't taken the Hippocratic Oath, look at things very differently than physicians do. We are very morally, ethically driven to do exactly the right thing for the patient, and we're passionate about that, as you heard from Dr. Nick. Like, we want to make sure these patients are taken care of the right way. And I understand hospital administrators are focused on the finances, and they don't understand what the doctors are seeing. The doctors are overwhelmed, the hospital's overwhelmed, but the administrators have this scarcity mindset often, not all the time, but often, whereas the physicians don't. There's plenty of patients, as Dr. Nick pointed out.
Anybody got questions for Dr. Squires? Senator Gooch, you are recognized for questions.
So I may have missed this in your talk. How do you handle people that are uninsured when they come into your offices?
So that's a really good question, and this is something that a lot of people outside of healthcare don't understand. Every day, patients are getting diagnosed with cancer who don't have insurance.
Mm-hmm.
And then also every day, there are patients who are getting treatment who have insurance, who've now spent all their money, and they can't keep paying their premiums, so they lose their insurance. What do we do with those people? Well, we have what we call patient account reps, and they educate the patients on their insurance. So when somebody comes in who doesn't have insurance, we say, oh, here's how you apply for insurance. We look at Medicaid, we look at different payers, we hook them up with insurance the best we can, and in that interim between the time that we have to start treating them and the time that they get insurance, we go and get free drug from pharmaceutical companies so that they can get treatment, life-saving treatment. And if they can't get insurance, or if they need services that we can't provide, like I already mentioned, some of the stem cell transplants, some of the other things, we send them to Wellstar, which is a 340B hospital, which buys the drugs at a 40% or more discount to what we can purchase the drugs for. And they charge 30% more than we do.
So, follow-up.
You can have a follow-up.
What percent of your payer mix is uninsured?
Probably 3 to 5% at any given time.
Okay.
So we don't meet the threshold. We're not a nonprofit. We're never going to meet the threshold for 340B pricing.
All right, thank you for being with us. You mentioned insurance. That got me intrigued here. I have Mike Riley from the Georgia Association of Health Plans that signed up to speak. I'd love to have your views on this legislation, Mike.
Yes, sir, Mr. Chairman, members of the committee. I'm Mike Riley. I'm the Vice President of the Georgia Association of Health Plans. We come to you today in support of Senate Bill 367, and I believe you also have a letter in your packets from our President and CEO, Jesse Wethington, that affirms that position. I'll be super brief. We think competition's a good thing. We also think that cancer patients should be allowed more choices when it comes to their care. And we also think that Senate Bill 367 would help remove some of the barriers that these patients are currently facing. And Georgians need more health care providers.
Think this bill would increase or lower health care costs for Georgians?
I think increased competition probably would lead to reduced prices, sir.
Yeah, how about insurance rates? We got a blue ribbon commission looking at y'all over at the House right now.
Right, absolutely. I think that's something that, is top of mind for Georgians and as legislators here. It would be good to see some of what other states have done, and I think looking at some of the other examples that some of our previous speakers have mentioned in South Carolina and other states where they've eliminated CON, we've seen some of those reduced prices, so it would be good to see, sir.
Your company deals with South Carolina as well?
No, sir. We just represent Georgia's insurance carriers.
Okay. So what's your information about healthcare costs being lowered in South Carolina after the elimination of CON?
I don't have that on hand, sir,
Okay.
but I'd be more than happy to do some research for you and get back.
Any other committee members have questions? All right, I'm intrigued. I have Sydney Roberts from Emory Winship Hospital here. Let's hear what Emory Hospital has to say about it.
Good afternoon, Chairman and members of the committee. Thank you for the opportunity to speak today. My name is Sydney Roberts, and I represent Emory Healthcare and Emory University. I am here to speak in support of SB 367, particularly on behalf of Georgia's only National Cancer Institute designated comprehensive cancer center in Georgia, Winship Cancer Institute. Winship serves patients from all 159 counties across Georgia, and we treated over 58,000 unique cancer diagnoses in FY25. Some members of the committee may remember that last year we came before you requesting letters of support to the Department of Community Health to open the Certificate of Need batch cycle for linear accelerators, or LINACs, which provide radiation oncology. At the time, Winship Midtown operated 3 LINAC machines that were running above 100% utilization consistently over the past 2 years and up to 155% utilization in April 2025. Each machine was treating more than 100 patients daily, significantly exceeding the state's threshold of 9,000 visits per machine annually. As you know, delays in cancer treatment can have catastrophic consequences for patients. We are thankful for the members of the General Assembly and DCH for supporting Emory throughout this process, and I am happy to report that we are waiting on the delivery of a 4th linear accelerator, one with even more advanced capabilities than the current 3. Additionally, Emory Healthcare has explored expanding our radiology services at Emory Johns Creek Hospital. CON applications were submitted in 2008, 2009, 2010, 2003, and 2024, but all were either withdrawn due to opposition or denied.
So that was Emory Winship, our nationally qualified group. You
Yes, sir.
couldn't get permission to expand.
Yes, sir.
Okay.
Either we withdrew due to opposition or were rejected.
Did you get that linear thing after we passed the bill last year?
Yes, we did.
I'm
We're
scared to try to pronounce it.
linear accelerator.
Yeah. So
we-
you're able to serve more patients now with that?
We are awaiting it. We were approved in June 30th, 2025 was when they opened the batch cycle. We were approved. There's about a 7-month design and then construction phase, so we're kind of in the middle of that right now.
Who are the biggest cancer treating programs or hospitals in the state? You're one of them, I presume?
Yes, we are the only NCI designated
Okay.
comprehensive
And
care
you're
center.
not afraid of competition in Fort Valley, Albany, Savannah, anywhere else without having to go to the CON process?
No, sir.
You're getting patients from all 159 counties, and you got enough business to keep you busy?
Yes. We actually have at least over 10 patients in 135 counties.
Why wouldn't you oppose this to keep competition away? Make those folks down there have to drive to Atlanta to get treatment?
Well, we, definitely appreciate all of our patients from all across Georgia, but we just want to make sure that they're getting the care they need when they need it and where they need it. And being able to, expand our radiology services is part of that.
Would the elimination of CON requirements for cancer treatment allow you to expand your radiology program?
Yes, sir.
Any other programs you'd like to expand that this would help you do? Make
I
it
can't
easier?
speak to other programs. I know that most of the excitement right now is expanding our radiology oncology.
Educate me on that. Radiology oncology.
Yes, so the
Now,
linear
radiology is taking x-rays or films, right? Or are you talking about radiation?
Oh, sorry. Thank you.
Okay, I got that. All right. So that's a treatment modality that's serious.
Yes.
You can't just give radiation treatment without a CON
Yes.
permission. And you're not able to get that. You would expand locations or the scope of your program? What are you wanting to do?
We would expand it. We would get a linear accelerator in Johns Creek, so that would make people in North Georgia have to drive a little less far for their care. And, after that, there's talk of more expansion, but I can only speak directly to Midtown and Johns Creek for immediate.
You willing to take your chances with the competition that the other folks would also be able to expand their radiology services?
Yes, we would.
Any other committee members got questions for Ms. Roberts? Senator Gooch, you're recognized.
All right. Sydney, does Emory support the full repeal of CON statewide?
We are actively working on reviewing the impact of a full repeal right now. We don't have a definitive position to share at this time, but we're committed to working with the General Assembly on a resolution to make sure that patients have access to care.
Thank you.
Senator Ginn, you're recognized for a question.
Thank you, Mr. Chair. Cindy, one of the things, I was born at Emory. I go to Emory to an eye doctor, said you've got campuses and facilities in different places. Said would this be just the Winship location, or would this be other locations? Would you build more locations around the state? What would this look like in reality?
I can't speak to the larger scale potentially exceeding our current footprint. And with Winship, right now we have our locations in our current facilities.
You think you would build other facilities?
I think that's probably above my pay grade, but I can get back to you with that.
That'd be great.
All righty. I'm hitting my limit. Pro Tem just had to go present a bill in Insurance Committee that I'm a member of, but I've got folks that have come from a long way to be heard here. Anybody that made special effort to be here today, let me know and I'll take you out of order. Monty Veazey came all the way from South Georgia? Okay. Well, I got Ray Williams is up ahead of you on the list. Ray, you came in all the way from Noonan?
All the way from Noonan, sir.
Try to keep it really brief for us here. I know there's a couple of us got to get to another committee
I'll
meeting.
do that. I first have to say I think I'm having a deja vu moment from being in this room 7 years ago. And where was this bill 7 years ago, 20 years ago?
I don't know if anybody else is here that remembers it.
Well, I don't know.
Well,
but I certainly do. But thank you for
and of
allowing me
course,
to speak
Senator
to
Lucas.
it. We are City of Hope now. CTCA was acquired by City of Hope in 2022. We became a nonprofit in 23, and we now have facilities. We're the largest footprint of cancer providers around the country. Southern California, big research clinical trial facility there. We are an NCI designated facility there in California, and that does sometimes accrue to our system, even though we're not NCI designated in Noonan. We support this legislation because it's about patients and it's about patient access. And the more opportunities patients have to be treated, the better off we are. We're not afraid of competition. Iron does sharpen iron, and I also think it lends itself to collaboration. We're in talks with multiple hospitals around this state, particularly in rural Georgia, to see how we can bring oncology to those areas that don't have it today. It's about the patient, and it's about the why. If you will, allow me to digress just a moment. 7 years ago, sat right there at that table, and I brought a lady in named Pam Alford, who was in support of our legislation. She was a patient of ours. She couldn't get in. She finally got in. I introduced Pam as the why to you guys. This is why we need to remove barriers to access to cancer care. And I'm going to mention something personal here, and it's about UCBC. My best friend and his wife, and our wife's best friend, is treating at UCBC. I want her to have the best care that she can get, access to the best equipment that she can get, the best care that she can get. She loves Dr. Gunn. I've tried to get her down to City of Hope, but she loves the way she's being treated at UCBC. This isn't about competition. It's about collaboration and how we can work together as facilities. It's about the why. There's not a person in this room that doesn't have a why about cancer care and why folks need to have access to it. So why you should support it is for your neighbors, for your friends, for your family that have cancer.
So I was here for that battle. We were CTCA
Yes,
at
sir.
that time. I bet there are a lot of lobbyists that retired on all the money they've made fighting you guys.
Some of them are still here.
Yeah, they're wealthy. They're the ones driving the Range Rovers and such. But teasing you there. Did you
Yeah.
put anybody out of business? You were fought tooth and nail that you were going to destroy health care in rural Georgia. You were going to put Northside Hospital out of business. And what was the effect on other medical providers in Georgia after your exclusive cancer treatment facility was allowed to open up?
To my knowledge, sir, no other hospital has gone out of business. And in fact, as we were talking earlier with the doctor from Augusta Medical, the modalities and the treatment plans that we have and the doctors all in one place have actually been, if you will, copycatted and fashioned in other facilities. So I think allowing us to be here to see more patients didn't put anybody out of business, and I think it enhanced cancer care around the state.
Any committee members have questions? Well, just in kind of the circle of life, you will remember Senate Pro Tem Tommy Williams was the proponent of that bill. I believe he was the sponsor.
He was.
He definitely drove it. And I don't know that it would have passed without his weight behind it. He is, I'm not revealing secrets, he is open about this. He is now been stricken with cancer and is getting treated at your hospital.
He is
That
indeed,
he
sir.
helped
Yeah.
create the pathway for y'all.
Well,
So,
and we
circle
wouldn't
of
have been
life.
here if it not been for Senator Williams back in 2008, and the work that Sheila Hummerstone and others did on there to get the bill passed. So thank you for that.
Appreciate you being with us. I've got one other piece of business I needed to mention to the committee. We passed Senate Bill 86, and I had the wrong LC number. The appropriate LC, this has already happened, was LC 560556S. And so I want to just clarify that's what we passed out. This was the one on the discounts for alcohol Tuesday afternoon. So reflect your records that the true LC number was LC 560556S. No words changed, but just want to make that clear on our record. Okay, unfortunately, we'll have to adjourn for today. We will resume this subject matter later. Monty, Anna, Chris, sorry, you are the three that signed up that I didn't get to yet. I understood that, Anna, that your group, Georgia Hospital Association, was neutral on the bill. Is that an accurate reflection?
Members on both sides of this argument, Mr. Chairman, so we are, at this point, just seeking clarity and looking
Okay.
forward to working.
If you have suggested refinements to this, bring them to me. Mr. Veazey, I understand your group's opposed to it, and if you would show us their problems.
That is not so.
Oh, really? I'm sorry. I saw a letter somebody had forwarded to me urging your members to contact us to oppose the bill, so I assume that meant y'all were opposed.
Opponents of CON have always had a history of supporting CON. We do not oppose the bill, but we do have concerns about the bill, and we would like the opportunity to work with you to narrowly define it.
Okay. Because I've had some committee members share with me emails that they got, I thought from you, requesting them to to your members to tell us to vote no on the bill, so I misinterpreted that as opposition.
No, but I said, we have concerns about the bill
Okay.
in its present form.
Well, please come share those with me as we try to work to get something that is good for Georgia.
Rachel King, who is with
Hey, Ms.
me.
King.
Rachel used to
Sure.
be Director of State Health Planning,
Great.
and she was going to express the concerns we have.
Great. Well, y'all, let's come see me before our next meeting, and Chris Denson, you already have, but if you've got any info you want to share with the committee, please do so. And with that, we are adjourned.